It's a pleasure being here as BC Children's newest member of the epilepsy team and as part of the BC Epilepsy Society as well. Today, my talk or my lecture is going to touch on seizures and epilepsy. I think having children in itself is a very daunting and frightening experience. And I think that having a child with epilepsy or someone with epilepsy in the family is even scarier. I think that part of this fear, though, stems from the unknown and not having enough information. And so hopefully I can alleviate some of that by going into what seizures and epilepsy are. I do talk quickly and very infrequently. I speak very softly. And so if there's any troubles with hearing me, or if you want me to slow down, or if you have any questions, please don't hesitate to interrupt me during this lecture. I also have left lots of time at the end for any questions that you might have. Okay? So let's start by going through my list of what I hope to accomplish through this talk. As I'm sure most of you are. I'm very task-oriented. And first of all, I'd like to talk about what seizures are and what the definition of epilepsy is. I'd also like to show you some examples. I know that all of you have probably seen some examples of seizures, perhaps in your own families or yourself, but I'd like to show you the various range that seizures can look like. And finally, I'd like to discuss some treatments available, although the majority will be touched upon by Dr. Mary Connolly later on today. Oh, are you getting a rebound? Okay, good. All right, so what is a seizure? It's worse. Do you want me to just take off this?
Actually, if I can just take a moment, I can turn off the mic here.
It's good? Okay. So what is a seizure? Is this a diagnosis of the modern age? Well, no. In fact, most of you will recognize that there's references to children with seizures, even in the Bible, dating way back. But what we know more now, what we know about seizures now, is that seizures are an abnormal behavior or a change in activity due to excessive and synchronized neurons firing off together. Now, this is kind of a fancy definition, but the basic principle is this is your brain here. Okay, these are the different cells or neurons, and they need electrical activity. So they need to fire off in a very controlled manner to do certain activities. So for example, if you're going to move your leg, then one brain cell needs to talk to the one neuron, needs to talk to the other to say move your leg. For example, if you want to remember something, it may be another surge of activity. But these surges of activity are in a very controlled manner. What happens is if you increase the excitement of these neurons, these brain cells, or if you decrease the containment of the electricity, then you end up with something called an electrical storm or a seizure. So it's excessive, and a whole bunch of neurons are firing off sort of without control, and this is what we call a seizure. Okay? So are there different kinds of seizures or different types of seizures? I think most of you know that there are, and because it's for the sake of simplicity, we like to categorize seizures into two types. The two types are partial seizures or generalized seizures. Partial seizures implies that it's coming from an area of the brain, and frequently the seizure manifestation is an activity that part of the brain will normally do, but excessively. Generalized seizure implies that it comes from the whole brain, or the whole brain is involved during the seizure itself. Now, partial seizures are divided into simple and complex, and we don't use this as much anymore, but for the sake of defining it, a simple partial seizure is where you don't lose awareness or you don't lose consciousness during the seizure itself. And complex means that the awareness is clouded or there's some degree of loss of consciousness. Partial seizures can definitely progress into a generalized seizure, and these are what we call secondary generalization. Okay. So what do seizures look like? Well, seizures usually have a beginning, a middle, and an end if they're partial seizures. Some individuals with partial seizures may get an aura or what we call a warning. So they know, and it's very specific to each individual, when their seizure is coming on, so they get a warning. Auras are not specific to seizures. You know, sometimes, yes? Oh, you can't hear me now? Okay. Better?
No, that doesn't help.
Better? You asked for it. Better? Okay. Let me take this off then. I'll restrict my motion, but that'll be okay.
Actually, I won't be able to hear you. Don't take it off.
Okay. Podium mic, AV. Is it because we did just... How about now? No? No? Just leave it as this? Okay. Do I need to repeat that last part? The whole part? No? Okay, good. All right. So some seizures have a warning, an aura, and then there's a seizure itself, and we'll go into what seizures themselves can look like, and then there's a post-ictal, or an after period, and we can touch a little bit into what that can look like. And sometimes it's very difficult, in fact, to differentiate what is actually the seizure and what is the post-ictal period. And in each individual, it does change as well. So in terms of auras or warnings, if somebody has them, there can either be no warning at all or no aura. Sometimes there's a sensory phenomenon, and what I mean by this is abnormal smells, like burning toast or burning rubber, abnormal tastes. Some people will describe a tinny taste or a very particular taste that they remember from previously. Some people will get nausea, so a feeling that they're going to throw up. Some people will get sounds, so sometimes they hear buzzing that gets louder or softer. And some people will describe things like feelings, so a feeling of numbness or pins and needles, tingling in one part of the body or the whole body. Some people get emotional or feelings as a warning. Fear and panic are very common auras that we do see, and you know it's very hard to describe. But for no reason at all, out of the blue, they get very frightened. Some people will have some psychic phenomenon, such as feeling of déjà vu, so a feeling that they've been there before when they haven't, or a feeling of depersonalization, so they're sort of outside their body and looking in, or they're going, you know, when they're doing something, they don't actually feel part of it. Auras are usually quite brief. Sometimes you can have auras without going to seizures, and sometimes you can have the seizure without the aura as well. Now, what do seizures themselves look like? Auras are probably the seizure starting, but once the seizure actually starts going during the event itself, some people can have body jerking. It can be anywhere from just a tiny bit of a finger, tiny bit of the face, to involving the whole side of the body, to involving the whole body itself. Some people will only have staring with unresponsiveness, and this is different from this, you know, the daydreaming spells. You know, these children or these people cannot be distracted from the unresponsive spell. Some people can have abnormal breathing, and sometimes at nighttime, that's how some parents recognize that their children are having seizures themselves. Some people just have difficulty speaking, or just some confusion, so confused speech or not making sense. Some people also have just what we call perseveration, so saying the same phrase over and over and over. Some people will have drooling with chewing and gulping motions. Some people will have eyes deviating or going to one side and being stuck there with some fine beating or some fine jerking of the eyes. Some people will have just eyelid fluttering, and some people may actually have tingling in a limb or in the face or the tongue or the whole body itself. So you can see that seizures differ from individual to individual, and really what makes them differ, it's the area of the brain that the seizures are coming from. And then once the seizure is over, is it over? For some people, yes, it is. Some people will just resume their activity, for example, with absent seizures, which I'll show you an example of, like they didn't even have a seizure. But some individuals will have a feeling of overwhelming fatigue, and frequently they'll go to sleep. Some people will have weakness on one side or of a limb, and this is what we call Todd's paresis. Some people have difficulty speaking, and sometimes that difficulty speaking is because one side of their face is weak. Sometimes it's difficulty speaking is in forming the words themselves. Some people will be confused, and this will last anywhere from a few minutes to even a few hours. Some people will complain of headache, and some will complain of memory loss as well. So it really does differ from individual to individual. So I thought I'd show you some of these, some examples of what seizures can look like. I apologize if this is going to be very graphic for some of you. These are individuals that we care for here at BC Children, so I would ask that we didn't videotape it or anyone take pictures. So this is a young boy who has one of the most common epilepsy syndromes in childhood, called benign Rolandic epilepsy. And this is during his EEG. He's sleeping, and you can see that the first thing that you see is his face is pulled to the right side. You can hear a lot of drooling. His right arm comes up and stiffens. Our technician asks him, can you remember the word elephant? You can see his face is pulled. There's jerking of the right side, a lot of drooling. But yet, with the left hand, he's able to squeeze the technician's hand. So he's still aware. Seizures are extremely frightening to see. And I think it's difficult for parents or for individuals to actually say how long a seizure is. This one's actually quite a brief seizure, but I think when you're there, it seems like it's forever. But this here is a brief seizure. It starts to slow, as you can see here. You can hear a lot of that drooling. It starts to slow. Okay. He's able to squeeze her hand with the left hand, but the right side is weak because this is after a discharge of that area of the brain, and it needs some time to recover. So he remembers the word. He remembers the word elephant. So this implies this was a simple partial seizure, and that he actually retained awareness during the seizure itself. And so this really shows quite a few points. The fact that it was a partial seizure, so on the one side, he retained awareness and was able to remember the word afterward. And then afterwards, you could see that he was weak on the one side. This is an example of a little baby who has partial seizures as well. And he was sleeping. He wakes up out of sleep. You can see that he is staring. There's some movements of his hands, but those look like baby movements, so that wouldn't be something you expect. His mother is trying to call him. He is unaware. And you can see that there are these chewing motions, these gulping motions, and he's not responsive to his mom. The other thing I don't think projects really wonderfully, but I want you to appreciate is his breathing pattern has changed a little bit, and there's a little bit of bluish discoloration of his face. But you can see that he is not aware during this, and that this is a different behavior from what he would normally be like. Yes, exactly.
As a baby, it's really difficult.
Oh, extremely difficult. Oh, yes, yeah. Oh, it's extremely difficult. And in fact, it's interesting you say that because, the reason this child, we did this child in the first place, because it was felt that, his breathing difficulties were from a chest infection. And so he was actually in the intensive care unit for this. And so, yes, you're right, medical experts, saw these events and felt that it was more of a breathing problem as opposed to a seizure. But this is not, this is just more to show you, the different range that they can be very subtle, the different range that seizures can actually look like. But you're definitely correct there. Okay, this is the final one. This is a seizure with an aura. This is again during an EEG. This young lady is lying still. She says she's going to have a seizure.
You're 7. What's 2 plus 2? 4. 4. Okay, what are you feeling right now, sweetie? Sick. What are you feeling? You feel sick? Okay. How about that smell? Are you having a smell? I'm gonna have it. You're gonna have it? Are you having it right now? What are you smelling? I'm not smelling it. I'm feeling like a bit of a seizure. Oh, okay. How's your stomach feel? It's okay, just that sometimes I don't get the seizure with the smell, but I was just starting to go to sleep, and then I was going like that a bit. You were, okay. And so what did you feel at that time? I felt weird inside. I always felt weird. Was that weird? Where was that weird feeling? Here, and here, and some here, and some in the butt. Is that right? Okay, how about over there?
So you can see that this young girl is able to articulate her aura. So she knows that, when the seizure is coming on, and she knows that there's a progression of symptoms sometimes that comes on and may not always occur. So this is, small little children to the age of 3 have actually told me or have actually expressed what we call an aura, or a warning that the seizure is coming on. But this one here is also a partial one, where she can actually speak during it and explain what's happening. Some example of generalized seizures now. This is an example of a generalized tonic-clonic seizure, which I think most people are familiar with, and certainly this is the seizure type that most people see in movies and such. Sorry. So you can see here that it's generalized stiffening, so that's what we call the tonic phase. And then the jerking part is what we call the clonic phase. Lots of time there's vocalization, such as this one, and there's complete unawareness during the seizure itself. These can be very brief, from less than a minute to more prolonged. And after the seizure is finished, she's quite sleepy and weak all over. Okay. This is an example of another generalized seizure type called absence seizures. These are most commonly seen in childhood absence epilepsy, which is very common in childhood as well. And this little girl is breathing deeply. What's some of the things we do in our EEGs? She stops. There's some blinking. She comes back to, and she's able to do what the technician asked her to do near the end of the seizure itself. But during the seizure, she was very unresponsive. So that too is extremely subtle. And frequently, when we see these children in our clinic, they've been having hundreds of these per day because they're really hard to recognize. This is an example of what we call an atonic seizure, or loss of tone. And this, as well as a generalized seizure type. You can see there's a sudden loss of tone, and you can appreciate that. If you all of a sudden have an unexpected loss of tone, this does result in quite a bit of injury to the individual with these atonic seizures, or also called drop seizures. Finally, the last seizure type I'd like to demonstrate is one called myoclonic seizure, or myoclonic jerks. Myoclonic jerks are not always seizures, but in this particular instance, you can see this little baby. And what you'll see is a very fast, lightning fast jerk of his, there you go, of his whole body. Okay. Sometimes it can be the whole body, sometimes it can be of only just one limb, or even of a finger, sometimes even of just the eyes. They're so fast, that it's difficult to tell. Usually they are. So if it's just of one limb, and certainly individuals who have many of them in a row stay responsive in between. So what causes a seizure? Seizures, as as Dr. Farrell, who you'll meet or you'll hear later on later on today, has always told me, what he says is seizures are really diarrhea of the brain. And what that means, I know it sounds funny, but it really stuck. And when he told it to me, so many years ago, I've always remembered it. And I always talk about seizures being the diarrhea of the brain. And what this means is, diarrhea itself is not a diagnosis. Diarrhea is a symptom that there's something wrong with your gut. So it could either be you have the stomach flu, you ate too much sorbitol gum or too many strawberries or too many fruit, or that you have an actual inflammation of the bowel itself. But diarrhea doesn't tell you what is causing the diarrhea. Diarrhea is just telling you that there's something going on in your intestines. Well, seizures are exactly the same way. Seizures are a symptom that there's something going on in your brain, that your brain is irritated. And this can be for a whole variety of reasons, and the reasons differ from individual to individual to individual. So there are many causes of seizures themselves, and having seizures doesn't necessarily mean that somebody has epilepsy. Seizures themselves might be due to an acute brain injury or irritation, so seizures from alcohol withdrawal or from low sugars or from head trauma. These don't necessarily mean you have epilepsy. But sometimes seizures may be due to a previous brain injury or inherited trait, and most likely, this is the cause. These seizures are the cause of epilepsy itself. So what is epilepsy? Some people also call it a seizure disorder. We know from actually a study that was funded here from the BC Epilepsy Society that 0.5% of children in British Columbia have epilepsy, and 1% of the population has epilepsy as well. Epilepsy is defined as a condition that somebody has where an individual has one or more seizures and a tendency to have more. So these are non-provoked. These are not provoked seizures in an individual. They have a tendency to have an electrical storm in their brain. So they have an area that is irritated for some reason, and they are likely to have more. Okay. What causes epilepsy? Well, the causes for epilepsy differ in everybody, and I don't think that there's two people in the room who have the exact same epilepsy. It may be due to an inherited trait, and Dr. Michelle Demos, whose specialty is in neurogenetics and epilepsy and genetics, she'll go on more to explain the link between the genetics or the blueprint of how you're made, how your brain is formed, and having epilepsy. It may also be due to previous brain injury, so it could be due to a previous stroke, previous decreased oxygen for a significant amount of time, previous brain infection like encephalitis, previous brain trauma which has been significant, previous having a brain tumor or a bleed which irritates the brain, having a brain which didn't grow as it should have, so having what we call a malformed brain or cerebral dysgenesis or cortical malformation. These are all words that we use. And also, I think the most frustrating sometimes is we don't come up with a cause, or we don't find the cause for someone's epilepsy. We know that there's something that's causing the tendency for seizures, but we haven't discovered it yet, either because we haven't discovered that cause, or we haven't discovered that gene, or when our technology just isn't good enough to actually find the abnormality. And I think that's very frustrating, I think. So what are epilepsy syndromes? This is another definition that I think gets confusing, but epilepsy syndromes itself are when individuals have similar features or similar signs and symptoms or similar clinical presentations. We can group them into something called a syndrome. Well, in epilepsy, it's the same thing. When there are similar features of epilepsy in a group of individuals, a group of children, or a group of adults, we can categorize different types of epilepsy syndromes. The reason we do this is not only because neurologists and especially epileptologists tend to be very detail-oriented, but because it does help us to predict the outcome of the epilepsy, and as also what the best therapies for this type of epilepsy syndrome is. So what are some common epilepsy syndromes in childhood? benign neuroleptic epilepsy and childhood absence epilepsy are one of the more common syndromes we see in the childhood group. Other ones are benign occipital epilepsy of early childhood, or Paniatopolis syndrome, juvenile absence epilepsy, juvenile myoclonic epilepsy. There's a whole list of them, and I'm certainly not going to list all of them. These are some of the other ones, and it differs between the population as well. Okay, we're on time. So how is epilepsy diagnosed? Well, epilepsy really is a clinical diagnosis. Your doctor will take a very detailed, sometimes painfully detailed, as some of you probably know, history in the clinic, and then will perform a physical exam. The diagnosis of epilepsy is usually made on the basis of the clinical presentation itself. An EEG is also used to aid the physician in the epilepsy syndrome, or what type of epilepsy the child has. An EEG, an electroencephalogram, is, I think that everyone in this room is probably familiar with them. But what it does here is, this is off our BC Children's EEG website, is electrodes are applied onto the head in a certain conformation. And what it does is it reads the electrical activity from the brain. And so this will help us to see if are there any areas of the brain which are irritated, or it helps us, because there's certain EEG patterns that you can see that are more in keeping with a certain epilepsy syndrome. And this is an example. I think that anyone who's had a EEG at our center gotten a picture with an example of what their EEG looks like. But what happens is that it comes out onto a piece of paper with lots of squiggly lines. Other investigations that may be performed, depending on what type of epilepsy that the child has, include a brain scan. And so this can either be a CT scan or a CAT scan or an MRI scan. Sometimes blood work can be performed, and sometimes genetic studies can be performed as well. But again, this differs from each individual, and there's never really a formula that we have for everyone. And how is epilepsy treated? Well, I think the most important thing to reiterate over and over are seizure precautions and seizure counseling. Sometimes we use anticonvulsant medications. And then sometimes in those who are medically refractory or do not respond to medications, usually 2 to 3 or more used appropriately, may go on to something called the ketogenic diet, or there's other modified diets as well, or epilepsy surgery. They may be candidates for that, which Dr. Conley will touch upon. Actually, we'll go into great detail after me. So what are seizure precautions? I think you guys have all heard this, and we do have a first aid poster, as well as online. You can get this information as well from the BC Epilepsy Society. But lifestyle is a really big player in terms of seizure precautions. Avoiding sleep deprivation and alcohol exposure is probably the most important. Avoiding stress is also important, but I think we all know that that's very difficult to do. Encouraging healthy diets and exercise. Ensuring children are healthy. I know it's sometimes really hard when you're scared that either, if you have epilepsy or that your child has epilepsy, that they may fall and injure themselves. But it is important to ensure that these children do lead healthy lifestyles. Ensure supervision around water, so ensuring that they're supervised around swimming or in the bathtub. And also other things that prevent harm when they're doing activities. For example, wearing a helmet with all activities that involve speed, biking, snowboarding, skiing, skateboarding, etc. Avoid climbing heights without a rope, and no driving until 6 or 12 months seizure-free. And the reason it's 6 to 12 months is it depends on each individual situation. What to do during a seizure? Well, I think the first thing to do is stay calm. You saw from my pictures that some seizures are not so frightening, but some seizures are really, really terrifying. And so the most important thing to do is to calm yourself, Keep the individual safe from harm. So remove anything that could be sharp or that they could fall upon. Best thing to do is lie them down if they lose consciousness. Don't put anything in their mouth. And I think that hopefully you guys have seen the article that Catherine Sykes, our social worker, had written that you can't swallow your tongue, and you can't. But don't put anything in their mouth because that they do clamp down quite hard. Gently roll them on their side into recovery position, which is, as you can see down here. And then call 911 or administer abortive therapy or administer medications that we have prescribed if the seizure lasts longer than 5 minutes. Okay. So anticonvulsant medications. Not all epilepsy requires anticonvulsants, and this is a decision that needs to be made between you and your physician, your treating physician. When I say abortive, I just mean rescue medication. So these are things that we use for individuals who have long seizures or prolonged seizures. We know that if an individual has a long seizure, that they're more likely to have long seizures in the future. So usually what we will do is we will give a prescription, and we'll show you how to give a medication that will help stop the seizures to prevent them from going on longer. Some of these you may recognize as rectal diazepam or Diastat, sublingual lorazepam, just in the cheek here, or Ativan, and intranasal or intrabuccal midazolam or Versed. Those are the trade names. Some medications require daily anti-seizure medications, and there's a whole list of these, and I certainly am not going to go into them. You may recognize some of these medications themselves. There are diets and surgery for those who are medically intractable or refractory, and Dr. Connolly will touch upon this later. And then I think the question that parents always ask me, and I think it's one of the hardest questions to answer sometimes, is will my child outgrow their epilepsy? And the answer is sometimes, and it depends. So it depends on the cause of their epilepsy. So many children with inherited epilepsy, for example, benign Rolandic epilepsy or absence epilepsy, these children will outgrow their tendency for seizures. And Dr. Demos will touch a little bit about the genetics of that as well. Although children may not outgrow their epilepsy during the time they have epilepsy, up to 70% will be controlled on medications. Okay? And then 20 to 30% may have what we call intractable epilepsy. It's also called medically refractory epilepsy. And these are children who have been on at least 2 or 3 medications used appropriately and have not responded. Okay? And then these are the children that would go on to other possible treatments. Another question that parents ask me, I think is very important, and I think that we're realizing the importance of this more and more now in terms of ensuring that families have the optimum quality of life, is what else should I be looking for in my child? Well, children with epilepsy, we know, are at higher risk of also having learning difficulties, of having ADHD or attention deficit disorder or attention deficit and hyperactivity disorder, behavioral difficulties, mood disorders, so depression, anxiety, and also sleep difficulties. Some of this may be due to some of the medications, but most of the time it's actually due to the same, it's also a symptom of irritation of the brain, so it's due to the same cause as the epilepsy itself. Dr. Farrell and Dr. Hamilton will go into these a little bit further and expand on that. But to be honest, sometimes these, what we call comorbidities, can affect the family much more than the epilepsy itself. And finally, where can I get more information? Well, your child's team of professional healthcare workers, so the physician, nurse clinicians, social workers, allied health, so dietitians, for example, the ketogenic diet, physiotherapists, occupational therapists, neuropsychologists. These are all people that are involved in the team to provide optimum care and optimum information to our families. There are websites, and unfortunately, Both fortunately and unfortunately, these days you can really find anything on the internet. But the most important thing is to make sure that the websites that you are on or the information that you're getting is medically approved or accredited. And two websites that I would recommend are of course, the bcepilepsy.com website, as well as epilepsy.com website too. Those are very good resources to look at. We also have many information sheets. These are available online at the bcepilepsy.com website, as well as at your doctor's office and at the BC Epilepsy Society office on Broadway. And so that actually concludes early, probably because I spoke so quickly, the talk. And I want to say thank you to all of you for coming out. I think it's really important to gather more information. And I think that you as families are probably are the most important in terms of the team caring for your children. I want to thank the the British Columbia Children's Hospital. The team here is just fantastic. They're wonderful to work with, but they're all extremely knowledgeable and extremely available as well. I want to thank the BC Epilepsy Society and the sponsors for today. They did a really fantastic job about organizing this day today. And I've left lots of time for questions. Should anybody have it? Yes?
Is it possible to have a copy of the information you gave us today?
Oh, that's an excellent question. And yes, there will be a copy of this presentation on the bcepilepsy.com website. For the protection of some of our families, the videos won't be available, but the rest of the information will definitely be available. Yes?
What is the ketogenic diet?
Okay, so the ketogenic diet is a special diet that we use in epilepsy. It's a very high-fat diet with very little amount of carbohydrates. And we don't exactly know how it works, but we do know it works in certain epilepsy syndromes, and Dr. Connolly will be touching upon that a little bit more. You're very welcome. Yes?
EEG.
Yes?
Can it predict the likelihood of seizures or just the activity of the brain at the time that the test is being done?
Oh, gosh. You have really good questions. So, both. It can, yeah. So, the EEG itself, this measures brainwave at the exact time of the collection of the EEG. But we do things to help increase our yield of the information it gives us. So here at BC Children's Hospital, we routinely ask for a sleep-deprived EEG. And so that doesn't only mean sleep-depriving the child, but also the family, unfortunately. And we wouldn't do it unless we felt that it was very useful. It is useful. It does increase the yield of the information we can get by up to 20 to 30%, depending on the studies you read. And so instead of having the child go through the EEG and then not getting the information we need and then coming back after sleep depriving them, we do the sleep deprivation right up front. We also do things like hyperventilation, so we get them to breathe deeply, which if any of you have done this for 4 minutes, becomes very uncomfortable. And we also flash lights at them to see if the flashing lights might be a trigger for their epilepsy or for their seizure type. And so with all of this, we get, out of the one EEG, the most information we can. So when we get the EEG, sometimes it shows the brain irritation on the EEG itself as we collect it, either during the wake, the sleep state, or sometimes we actually are lucky enough to catch seizures. And then the EEG findings at that time will help us predict the syndrome and whether or not the child will be able to outgrow the seizures in most of the time, and will help us show where the area is of irritation. And sometimes this may help us with getting a scan. Sometimes it may be normal at that time. And sometimes, and I'm sure some of the families here have children who have had normal scans. Sometimes the area of irritation is so deep in the brain, or is in an area where recording it from the outside of the brain is very difficult. And so sometimes the EEG may still be normal, which is why we perform EEGs already having a pre-EEG suspicion of epilepsy or of seizures itself, because although it can give us information, it can be normal, and we still have to go right back to what the information we got from the history and the physical itself.
You wouldn't use
yeah, no, that's so. What else do we use epilepsy for? I mean, the EEGs for. We do that. We do sometimes use it for response to medications. Not only for, for example, some seizures are so subtle that. Each EEG is done with a video, but some seizures are so subtle that it's very difficult for parents to recognize, and we see them on the EEG itself. Sometimes some of our maneuvers to bring out seizures, which are not normally done in in everyday life, will bring out seizures, and we know that they still continue to have a tendency to have seizures on the EEG. So we do it in order to sort of help us with adjusting our therapy. Sometimes we do it because children with epilepsy may have events which are not epileptic seizures. Sometimes they can have jerks or sometimes events that do not come from the outside of the brain. And sometimes the EEG can also help us with distinguishing what are seizures and what are not seizures. Because as you can tell from some of these examples, sometimes seizures are very difficult to ascertain whether or not they're epileptic or not. Yes, you up there.
Can you talk a little bit about the effects of those medicines that you
Yes. Dr. Connolly, will you be going into that?
A little bit.
A little bit? Could I defer that? Okay. Yes, sorry.
Those children who have seizures due to the high fever, do they grow up?
Oh, okay. That's a great question. So the question was, the children who have seizures with high fevers, do they outgrow these? I had thought about putting febrile seizures into this talk, but then I thought that I would run out of time, so I'm glad that you brought that up. So febrile seizures occur in up to 4 to 5% of children. And these are seizures which occur during childhood between the ages of 6 months to 5 years. These children have seizures with high fever. They can have anywhere from a single seizure to multiple seizures. And these children do not have epilepsy. These children have febrile seizures. And this is after, if they fit the clinical picture of febrile seizures. They will outgrow them. Most children will outgrow the febrile seizures themselves. There is a slight increased risk of having epilepsy. And it's more likely that, during the time that they were having the febrile seizures, there was actually, either epilepsy, which manifested earlier. Seizure will increase fever will increase the seizure thresholds or make a seizure more likely to happen. So they may have had epilepsy, and that was the time that their seizures were appearing. Or there are some individuals who, rarely have another type of epilepsy after febrile seizures. And this is more common with something called mesial temporal lobe sclerosis.
Say that again, please. You just said.
So, sure. So, yeah, so febrile seizures, simple febrile seizures in themselves, children will outgrow all of them. But some children who have epilepsy may, a fever will decrease the seizure threshold. So it makes seizures more likely to happen in an individual. And I think most parents recognize that fever is one of the common triggers of their child's seizures or their child's epilepsy. But certain individuals with epilepsy, the seizures may start happening with fever at an early age, and they don't actually have what we call benign febrile seizures. They actually have, epilepsy, but it was manifesting, with the fever at that earlier age. So they're two different.
Like 10 years or 15 years between they have febrile seizures and then have seizures in their teens.
Yeah.
Is that just two separate things?
No. So children with febrile seizures. The prevalence of having epilepsy in the population is 1%. And children with febrile seizures, the risk of having epilepsy or afebrile seizures and a tendency to have more is 2%. And so we know there's certain risk factors, or there's certain individuals with febrile seizures who are more likely to go on to have epilepsy. And those risk factors or these traits in these individuals would be a family history of having epilepsy, would be having some abnormality of development or their physical exam in terms of neurologic physical exam, and also having what we would call a complicated or an atypical febrile seizure. So yes, there are individuals with febrile seizures who actually go on to have epilepsy. And in some individuals, like I said, a very small subset can go on to have, another type of epilepsy in the future called mesial temporal lobe sclerosis.
And that's the last word I needed to hear?
Yeah, mesial temporal lobe sclerosis. I don't know if we'll be touching on that, but oh well.
I have another question related to that actually. Those children who, because of their high fever, they start talking that makes no senses.
Mm-hmm.
Is it a kind of seizure too?
So the question was, sometimes when children get high fevers, they start talking senselessly. Most of the time, actually it's hard to say, although you can have seizures with high fever. You can also, I don't know if anyone's had, I'm sure everyone's had this experience, but when you have a high fever and you're unwell, sometimes you can get things like rigors, so shaking, and also some, what people call delirium. So sometimes children, when they're unwell, may have, confused speech. But it is something to look for and, to bring to the attention of your physician. But no, not all high fevers will cause seizures, no. Yes?
Some common expressions I used to have heard referring to epilepsy is like grandma and petit. I mean, that wasn't mentioned in your discussion. Is that the difference between partial and generalized?
Oh gosh, yeah, I'm sorry about that, actually. I'm sorry about that. Yes, that was the old classification. And, we've started to use the new classification because it was so confusing. So the grand mal is the generalized tonic-clonic, but people would use it for, any jerking seizure type. And then the petit mal, people used to call the partial seizures, but people also call, the absence seizures, which are generalized seizures, petit mal. And then, people would divide, into these two. So we sort of got away from that, but thank you. I didn't mention that, but thanks for clarifying that. I'm sure lots of people are actually wondering that. Okay, Elvira's telling me I have time. Well, thank you very much. Oh, one more question? No? Yes? Okay, just the last question. Hi.
You mentioned that the post-ictal time after a seizure can be difficult to identify between what is the seizure and what I heard you say, what is post-ictal.
Yeah.
When you read, most people have written that to treat the seizure after 5 minutes the medication. If you have some doubt as to what is the seizure and what's going on afterwards, for many parents looking at their children, this probably is
Oh, undoubtedly. Yeah.
and you sit there and you watch and you go,
Yeah.
should I do it now? Should I
Yeah.
do it now? And you know the aftermath of giving
Yeah.
the medication. Is there anything that you
Yeah, no,
would
you know what?
suggest?
It's that's really hard. Yeah, it's a really hard issue. So what I would suggest is to err on the side of caution and to treat. And sometimes even for us it's very difficult. Even when we have the EEG electrodes on the brain, sometimes it's difficult to see what's, only then can we see what's post-ictal and what's the seizure itself. So if there is any doubt, I would, treat with the therapy that we had recommend. And the reason we do this is because we know that prolonged seizures or very long seizures, more than 30 to 60 minutes, can be harmful to the brain itself. So, we try to minimize this by treating early and by treating adequately. But yeah, it's really hard, but okay. All right.
Well, Linda, we have time for a few more questions.
Okay. Yes.
My son is 3 years old. He's been having a seizure since he was 3 days old.
Oh gosh.
My question is, his seizures go from partial to generalized.
Mm-hmm.
And at the end of it, and it's pretty well controlled now, he used to have up to 30-minute long seizures. He's having several a week, 5 seconds to 15 seconds long. Sometimes, and with febrile, seizures will go up to an hour, that's a given. After the seizure, sometimes, and he is developmentally delayed, he's got lots of complications, but I've been told by the neurologist over and over again that he doesn't know what's going on. I tend to disagree because sometimes he comes out of it so happy. It's like, I have to do that to get it out of my system. And sometimes he cries. So he what's going on. And I've heard from several neurologists who have treated him, you being one of them, what is it called? He's just cramping, and that's why he's uncomfortable. I tend to disagree. I think he is just scared after the fact.
Oh, definitely, yeah.
Before.
Yeah.
But I guess the question is, why is he sometimes happy after?
Yeah.
And why is he crying?
Yeah. I don't know the answer to that. You know, there's a lot we don't know in epilepsy, and it's probably the area of the brain that was affected. You know, we know that, that there are certain areas of the brain that control, fear, happiness, sadness. And, if I said that they didn't feel, if they weren't aware during the post-ictal, then I apologize if, that was communicated wrongly. But I do think that they are aware, and I do think that's why it's important to put them in the recovery position, assure them that they're safe. And that, even during the seizure itself, because you could see from, the first, a couple of partial seizures I showed you, that they are aware. And so I think it's important for them to know that, they're in a safe environment, that they're being, that mom or dad or, care worker is near them and keeping them very safe. But it's probably the area of the brain that was affected during the seizure itself.
We have a question here?
Yes. Yes. Were you stretching now?
You may have just answered this, but I've been getting conflicting answers about when does a seizure cause further brain trauma or damage. I've had some ER nurses tell me 20-minute seizures. I had my neurologist, after my daughter had a 2-hour seizure, say they called it 2, but it was a bunch of little ones, don't worry about it. It's not going to cause any further damage. So is there sort of standard?
Yeah,
I suppose I can say about when a seizure can cause further damage?
Yeah, I would love to answer that question, and so would many research councils. It's the one answer that we're trying to, amongst other issues around epilepsy, what we're trying to find out. What actually causes injury to the brain, and so. Undoubtedly, what happens during a seizure is you miss out on everything that's going on during the seizure. And some people will find that they actually lose some memory that happened before the seizure if it was a big one. But it does depend on the seizure type, it depends on the individual, and it depends on the frequency of the seizures themselves. What we have is, we have data more from experiments on animals, which, as you know, are not are very different from, child's brains, babies' brains, adults' brains. And so we use the word 30 to 60 minutes in order to help guide us in terms of when to treat a seizure, but we don't actually know that. For example, there have been studies that showed children with febrile seizures have had long seizures and have not had any difficulty after them. But there, are reports of children who have for example, children with absent seizures. They'll have 100 of very mini seizures per day, and yet, they still, after the epilepsy goes away, they function fine and they're back to normal. But there are individuals who have very frequent seizures throughout the day and actually have, difficulty with learning or difficulty with acquiring new skills. And there are people who have seizures after, say, 30 minutes, and who say that they can't remember things for days beforehand. So I think in the end we're going to find out it's actually a very individual thing. I think it's going to depend on who the seizure occurs in, what type of seizure it is. And until then, I think we can only use these very general statements that we try to prevent a seizure from happening after 5 minutes, because we know that after 5 minutes it's likely going to go on for 30 minutes and possibly longer, and that we want to keep it definitely less than 30 to 60 minutes because of the potential harm that could happen. But hopefully, we will find out more. I think there's lots of research going on in epilepsy right now, and that'll help us define that. Yes, up there, and then you, I promise. Yes, please.
I just have a question regarding that. I've never understood why we should have to, wait 5 minutes and give a child something like diazepam.
Oh, okay.
Like personally, my son at this stage, that as soon as he gets a seizure right now, I give him
Yeah.
something. But
Yeah, so these are all really great questions. So the question was, why should I wait 5 minutes before treating my child with anti-seizure medications when I know that he's going to go on to have a long one? So this goes back actually to the same principle, is that we know that if a child has a seizure for longer than 5 minutes, that they're more likely, not always, but more likely to go on for longer. And so that's why we use the 5-minute mark. We say 5 minutes because, seizures may stop before 5 minutes. And, if they're going to, lots of people will identify their own children. Oh, they stop at 2 minutes, at 3 minutes. And so the 5 minutes is more from what we know about, big research groups or the generalization of it. The reason we don't give a child medication every time they have a seizure is because, medications all have side effects. And sometimes if you use a medication very, very frequently, like this rescue medication, sometimes, the response to it can decrease over time if it's used frequently. So that 5 minutes is really something that, we use as a general statement. But many parents will say, I know if he's going to have one, it's going to be long. So I'm going to I'm going to give it as soon as I get ready. And to be honest, as soon as you start seeing it, get everything ready, it's 5 minutes anyway. So it does differ from people to people. Did that answer your question?
Yeah,
Yeah.
but I don't get it. It's just, last time he was in the hospital and he was having seizures in the
Yeah.
emergency room, and they waited 5 minutes
Yeah.
to see if he's going to stop it.
Yeah.
He didn't, and he ended up going through this status, and he ended up in ICU for 3 days.
Yeah.
So that's why I don't.
Yeah, so it's because it's from the studies that we know that, if a seizure is going to stop, it's going to stop by 5 minutes. If it goes on longer than 5 minutes, it's likely not going to stop. And, some of the medications we give can cause side effects. So we do try to only use them when we have to. And I promised you in the back there.
Regarding the generalized tonic-clonic
Mhm.
and the recovery position.
Yes.
How important is it to try and get that person in the recovery position? And if you can't,
Yeah.
what should you do?
If you can't, you need to do what you can to keep yourself and to keep your child safe. The reason the recovery position the reason we use that is because they're lying down, and in case they vomit after a seizure, it drains out of the mouth on their side.
So it's not to do with the abnormal breathing,
No.
per se.
Well, if they're on their back, sometimes, since everything is sort of weak after a seizure, sometimes it's harder to breathe because the breathing tube collapses. So that's why this also helps open it up so that they can breathe. Another position you can do is tilting back the head to open up that airway as well.
So if they were sort of in a sort of semi-sitting slump kind of way, the head going back would be better?
Yeah, or forward so that they could, if anything comes up like saliva, drool, vomit, it can come out that way.
Or if they were laying like flat,
Yeah.
then
Yeah.
to the side more?
Mhm. And so, that position is more because you can, it's a very stable position. Sorry, I should just go back to it. You can see it's a very stable position. They can't really roll back, roll forward, and it helps drain things out of the mouth. The neck is extended so that, the weak muscles will help, will not collapse and obstruct breathing. Elvira, you're going to let me know when, yeah? Are we, one more question? Okay.
I was wondering, for seizures that occur at nighttime, if you know of anything that can help assist a family with regards to the safety at nighttime, if they are prolonged, and
Yeah.
hopefully you do get some sleep as a parent.
Yeah. Oh gosh, yeah.
Like, do you know of anything?
I do. So the first and foremost is please don't sleep with your children, especially once they reach their teenage years. No, I mean, you laugh, but there's also some guilty looks here in the audience, I'm sure. It's extremely frightening as a parent, I know, to see your child having a seizure, but it's also really frightening to think that you might miss your child having a seizure, and if it goes on quite long. And so lots of parents do actually sleep in the same room, sometimes in the same bed as their child, because they feel that they'll wake up better, or easier if the child has a seizure. I would discourage this. I think it's, I don't think it's good for the dynamics of parent and child and for the child's independence. Some people find that having a baby monitor and in recognizing the noise, it's interesting. But a lot of parents do tell me that they're afraid of this. But it's amazing how they know that their child is having a seizure from the sounds, from very subtle sounds. And so perhaps for the first few nights, parents are hyper vigilant and can't sleep very well. But with this baby monitor, you can definitely hear them. Just think of when your child were babies. Remember how they used to just wake up for feeds and used to, with the slightest little noise, you could hear it through the baby monitor. And I think that helps with sleep because the families need sleep.
I'm thinking more prolonged, so you have the baby monitor on, and if they're seizing 40 times at nighttime,
Yeah.
and they're short, you're waking up 40 times.
Oh, I see.
Wake up
Yeah.
because you hear it.
Right. Yeah.
That's kind of what our position is, but you just don't want to not catch the longer one, and I
Yeah.
don't know if there's anything in the
Yeah.
market or if you've ever seen anything in the hospitals that help to identify a more prolonged.
Yeah, so there are some things like blankets and alarms, but they're meant to pick up any seizure as opposed to really long ones. So unfortunately, it's hard. Sorry. Okay, we're good. Okay.
Thank you.